Kawasaki disease is an acute febrile illness in children, usually less than 5 years of age. It was first described by Tomosaku Kawasaki in Japan in 1967. Now, Kawasaki disease is known to occur globally. Important features include fever, rash, swelling of hands and feet, lymphadenopathy, and involvement of eyes, lips, throat, and coronary arteries. The most important sequelae of Kawasaki disease is coronary dilatation and aneurysm formation. As per data available on the US Centers for Disease Control and Prevention website, incidence of Kawasaki disease ranges from 9 to 20 per 100,000 children below the age of 5 years. 5,440 hospitalizations with Kawasaki disease were reported in children under 18 years of age in the United States in 2016. Of these, 3,935 children were under the age of 5 years. This corresponded to a hospitalization rate of 19.8 per 100,000 children in that age group. SED score has been used for classification of coronary aneurysms in Kawasaki disease. American Heart Association classification of coronary artery aneurysms based on SED score is as follows. 1. No involvement with SED score less than 2 always. 2. Dilatation only with SED scores from 2 to less than 2.5 or a decrease in SED score of 1 or more during follow-up if it was less than 2 initially. 3. Small aneurysm with SED score of more than 2.5 but less than 5. 4. Medium aneurysm with SED score 5 or more but less than 10 and absolute dimension less than 8 mm. 5. Large or giant aneurysm with SED score 10 or more or absolute dimension 8 mm or more. The decrease in dimension in class 2 over time means that though the diameter was in normal range initially, it was actually dilated for that person and decreases in size over time. Factors which favor regression of coronary aneurysms in Kawasaki disease. 1. Age less than 1 year at onset of Kawasaki disease. 2. Smaller aneurysms have greater chance of regression. 3. Distal aneurysms are more likely to regress. 4. Fusiform aneurysms regress more often than saccular aneurysms. Overall, about half to two-thirds of coronary aneurysms in Kawasaki disease have been shown to regress on angiography within 1 to 2 years of onset of illness. In contrast to coronary aneurysms which can regress with time, stenotic lesions are more likely to progress as they are due to intense myointimal proliferation. Progression of stenotic lesions are more likely in those with giant aneurysms. Worse prognosis is for those with giant aneurysms of 8 mm or more diameter. Though echocardiography is the most commonly used investigation for aneurysms in Kawasaki disease and coronary angiography the gold standard, MDCT is a useful non-invasive modality for long-term follow-up. Ulnastatin, a urinary trypsin inhibitor and a suppressor of neutrophils, has been shown to reduce the rates of coronary lesions in patients with Kawasaki disease. Higher plasma levels of neutrophil elastase and markedly activated neutrophils have been associated with poor response to intravenous immunoglobulin and coronary artery lesions in Kawasaki disease. The retrospective study could identify 369 patients who were treated with a combination of ulnastatin, intravenous immunoglobulin, and aspirin. 1,178 patients who were treated with IVIG and aspirin served as the control group. Long-term data on follow-up of patients with Kawasaki disease and giant coronary aneurysms is available. 76 patients with giant coronary aneurysms from an institutional database since 1972 were identified. The average age at onset was about 3 years, and the median follow up was about 2 decades. 7 of them died, and 1 underwent cardiac transplantation over the follow up period. The survival rates calculated were 95% at 10 years and 88% at 30 years. About two-thirds of them had undergone surgical or catheter-based interventions to alleviate coronary ischemia. The authors called for further research on the role of coronary interventions in those with coronary aneurysms following Kawasaki disease. Here are the first set of references. Second set of references. Third set of references.